Committee on Health Services. Everyone knows, I think, that we had a name change and a new committee that was established. So we are the House Standing Committee on Health Services. This is meeting 1. And I'd just like to thank everyone for being here today. We will go ahead and have the secretary take the role, and then we will allow new members to briefly introduce themselves for everyone's knowledge. So,
Representative Bentley. Here. Representative Bratcher. Here. Representative Bray.
Here.
Representative Burke.
Here.
Representative Callaway. Here. Representative Duval. Representative Fraser Gordon.
Here.
Representative Justice. Representative Neighbors.
Here.
Representative Rayborn. Representative Raymer.
Here.
Representative Riley. Representative Rorks.
Here.
Representative Sharp. Representative Swan. Representative Weber.
Here.
Representative Wilner. Representative Witten. Vice Chair Dotson. Present. And Chair Mosier.
I am here. Thank you. We have a quorum and are established to do business. And I will hand it over to my co-chair, Senator Meredith, at this time.
Thank you, Madam Co-Chair. And this is a history-making day for the Commonwealth. First time that we've ever had a Health Services Committee, at least to my knowledge, and we're very excited about it. It was a recommendation that came out of our task force this summer on the reorganization of health and welfare, and we'll talk about that in more detail later, but very pleased that we're able to have this meeting today, and in large measure because we have so many new members of our committee that we want to try to bring up to speed and be prepared for this next session. So with that, we will proceed with roll call.
Senator Berg. Senator Carroll.
Here.
Senator Douglas.
Here.
Senator Funke Fromeyer.
Present.
Senator Nemes.
Present.
Senator Tishner. Here. Senator Wise. Vice Chair Rocky Adams. Chairman Meredith.
Present. We do have a quorum.
Okay, at this point, I would like to give, as Senator Meredith said, our large number of new House members, and actually all members, just a moment to quickly introduce yourself for the record and for everyone here in the audience to kind of get to know one another. We have put this meeting together to just increase everyone's kind of general knowledge of the cabinet, inner workings, and funding streams. So I will, I'm going to start with Representative Bentley. If you can just tell us where you're from and maybe a 20-second little bio.
Representative Bentley, District 98, Northeastern Kentucky, and I used to raise horses.
Thank you. Representative Steve Bratcher.
Steve Bratcher, I'm from the Elizabethtown area, Hardin County, District 25.
Representative Josh Bray.
Josh Bray, 71st District, reside in Rockcastle County.
Okay. Representative Lindsay Burke.
I'm Lindsay Burke, House District 75 in Lexington. I'm a social worker and attorney.
Representative Emily Callaway.
Hi, I'm Emily Callaway, District 37, which is Jefferson County and Bullitt County. Those are 2 new precincts in Bullitt County, and it's in the Louisville area. Thank you all for coming.
Next, we have Representative Deanna Fraser Gordon.
Hi, I live in Madison County and represent a portion of Madison County, and I am an audiologist in my day job.
Thank you. Representative Amy Neighbors.
Hello, my name is Amy Neighbors. I represent the 21st District, which is in South Central Kentucky. I reside in Metcalfe County. I'm a licensed nursing home administrator and recently retired from a 22-year career at my local nursing facility.
Thank you. Representative Rebecca Raymer.
Hi, I am Rebecca Raymer. I represent District 15, which is Butler and Muhlenberg counties. I'm a registered nurse, and I have worked for 19 years at the same local hospital in Bowling Green.
Representative Rachel Rourks.
Good afternoon, everyone. I'm Rachel Rourks. I live in South Jefferson County and represent the 38th House District there. Thank you.
Thank you. Representative Russell Weber.
I'm Russell Weber. I represent the 26th House District that includes parts of Bullitt County and part of Hardin County. I will now be beginning my 11th year on this committee and one variation or another under different names. So I look forward to continue the work that we started many years ago.
Thank you so much. And then Representative Ryan Dotson, Vice Chair.
Thank you. Ryan Dotson. I'm from Clark County. I represent the 73rd District, which is all of Clark and the southeast portion of Fayette County. In my past life, I was a combat medic as well as a certified radiologic technologist. Thank you.
Okay, thank you so much. And I am Chairwoman Representative Kim Mosier. I represent the 64th District in Northern Kentucky. I have served in the legislature since 2017 and have been on this committee the entire time and have chaired since 2019. And my past life, I was a neonatal intensive care and flight nurse for a lot of years and served as the executive director for the Northern Kentucky Office of Drug Control Policy. And I am just delighted to be here and be back and honored to be chairing this committee. And at this point, I just will hand this over to Senator Meredith so that we can get to know some of the Senate members. But thank you all for being here.
Thank you, Madam Chair. Let me start with the members who are not here because you'll see them throughout the session. Just sure you're familiar with the names. And that would be Senator Julie Rocky Adams, who's also our caucus whip, Senator Karen Berg, and Senator Max Wise. But members who are in attendance, let's start with the greatest of all time, Senator Douglas, if you would, sir.
Good afternoon, folks. I'm Senator Dr. Don Douglas. I represent the 22nd District, which includes Fayette County, Jessamine County, and Garrett County. I'm an anesthesiologist. I've been in healthcare over 30 years, and it is entirely my pleasure to be a part of this committee now. Thank you.
Thanks, Senator Douglas. I should note that he will be vice chair of our Senate Health Services Committee. Senator Danny Carroll.
Danny Carroll, I'm the state senator from the 2nd District, and that's in far west Kentucky. I'm a retired police officer, and for the last 12 and a half years, I've served as president and CEO of Eastern Seals West Kentucky, where we provide services for typically developing children and adults with developmental disabilities.
Thanks, sir. Senator Shelley Funky Frohmeyer.
Yes, thank you. I am the representative from the 24th District, which is Campbell, sliver of Kenton County, all of Bracken County, all of Pendleton County. And in my day job, I am a holistic financial advisor as a certified financial planner, and I'm very committed to a holistic health revolution.
Thank you, ma'am. Senator Michael Nemus.
I'm Senator Nemus from Bullitt County, and then I have some of South Jefferson County.
Senator Lindsay Titchener.
Hi, Lindsay Titchener. I'm from Senate District 6, which is Oldham County, Trimble County, and part of Northeast Jefferson County. I'm born and raised in Oldham County and reside there today with my family, and I'm honored to serve on this committee.
Thank you. And I'm Senator Steve Meredith. I represent the 5th District, which is Meade, Breckenridge, Grayson, Butler, and Ohio counties. In my previous life, I was a hospital CEO for 210 years because it's sort of like dog years. Every year is 7. I have been in the legislature since 2017 and had the honor of serving on what was the Health and Services Committee and working with Co-Chair Moser, and I'm looking forward to some great things. And as we get into this agenda, I think we'll talk a little bit more about the task force this summer on the reorganization efforts. And again, obviously, this committee was one of the efforts that came out of that. So with that, Madam Chair, back to you.
Thank you, Senator Meredith. And at this point, since we have established a quorum in both the House and the Senate, I think we will take an opportunity to go ahead and consider the administrative regs that we have on the agenda today. There are 18 of them. All members have received these regs and summaries, and we do have one regulation which we will talk about in a second, but did everyone on the committee have a chance to read the regulations? Is there any discussion? Okay, hearing none, we will consider these regulations reviewed. We do have 910 KAR 001090, a proposed regulation related to personal care attendant programs and assistance services. We do have an amendment which we will need to take action on, but at this time, I would like to invite, I think, Victoria Eldridge. Commissioner Eldridge, are you here? Thank you. If you wouldn't mind just explaining the regulation and the amendment before we address this, I would appreciate that.
Good morning, afternoon. My name is Victoria Elridge. I'm the Commissioner for the Department for Aging and Independent Living. The Personal Care Attendant Program is a program to serve Kentuckians with severe physical disabilities. The regulation was updated to go from what was written in statute to change the pay from $7.25 at federal minimum wage to up to $11. Was there a specific piece within the regulation that you wanted additional information on?
I don't, but I will ask the committee if there are any questions or concerns. Okay, hearing none. Thank you for that explanation, and I will entertain a motion on approving the amendment on this regulation. From the House. I'm sorry. Yeah, we're joint. So from the House, I need a motion and a second. We have a motion. Do we have a second? Second. All in favor, please indicate by saying aye. Any opposed? Okay.
On the Senate side, we'll also need a motion. Let's not be shy. Thank you, Senator Douglas. Motion, seconded by Senator Carroll. All those in favor say aye. Aye. Any opposition? Thank you. Okay. Carries.
Yes. All right. Well, thank you. That takes care of the regulations, and I will hand it back to Senator Meredith to introduce our next guests and presentation.
Most certainly will. And when Chairwoman Moser and I talked about putting this together, it was to try to give everyone an overview, particularly the new members, as to what the largest cabinet in state government. And this will be like drinking from a fire hose, but I'm confident that Secretary Freelander and his people will do a great job of giving us an overview of the cabinet. And then we probably will get into some discussion about the recommendations from the task force, because what he's telling you today may not be what we'll see in the future, and give us a chance to have some dialogue. So with that, Secretary Freelander, if you'll come forward and introduce yourself for the record and jump right into it.
Thank you. Appreciate the opportunity. As always, appreciated the task force and the opportunity to present the Cabinet for Health.
Is your microphone on?
Yeah, it is.
Okay,
I maybe need to be closer. Sorry.
Maybe. Thank you.
So always appreciate the opportunity to talk about the Cabinet for Health and Family Services as a whole. Oftentimes, folks come to the Cabinet and see pieces, right? They'll see Medicaid. They'll see Child Protective Services. Let me see if I can do this. You're happy to drive. This is what I want to kind of convey, is that the Cabinet is a very large organization. 6,000 folks. The budget is 18 billion with a B. So most of that is Medicaid, about 15 of that. So you have somebody from Medicaid who will be after me to go more in depth into Medicaid. Trying to do the Cabinet for Health and Family Services in a quick and efficient way is what I'm going to try to do today, or otherwise we'd be here till tomorrow. So for new members, I want to say, please reach out. I'm happy to meet with anybody. I think the chairs and some of your other folks here will tell you I'm absolutely willing to meet and would love to do that and love to go down and talk about specific concerns. I think it's important that you get to know me, you get to know the cabinet, you get to know our different programs. So I'm looking forward to that and looking forward to today. I'm going to try to run this. Oops. He says. Now I just knocked it all out. Oh, look at that. This is going to be the better way to do it. So as Senator Meredith said, the Cabinet for Health and Family Services is currently configured in this way. There is a bill that has been filed that would change this some. I began at the Cabinet in 1985. Maybe some of you weren't born yet. And so, yes, Senator Meredith, yes. I have been in various departments of the cabinet. One of the running jokes we had at the task force is I've been over a lot of these programs. I'll highlight that for you as we go through. I was what I referred to as the utility infielder for the cabinet. Those of you that like baseball, the three of you left. And that is that they'd set me about to go into departments to kind of hold the space until they were able to get somebody permanent. So I learned a lot about different parts of the cabinet. And so hopefully I bring that full experience. I learned something every place I went. Full experience to the entire cabinet. So Health and Family Services Cabinet. You all can see for yourselves all of the different programs that we have. There are what I call the big five departments. That's public health, Medicaid, aging and independent living, DCBS, and behavioral health and developmental and intellectual disabilities. Those are our five biggest departments. The rest are small in comparison, but do very important things like family resource centers. So these are the components of the cabinet. Many states have these kind of cabinets broken up into different pieces. We in Kentucky have done that once. We broke this cabinet into two big different pieces. I've served through the breakup, the reunion, and I will tell you, as I have looked at other states and talked to other states, I firmly believe that having the cabinet as a whole, as one piece, because so many of these programs overlap. And you may hear a little bit of that as I go through, but I think there are about a little over a dozen states that have big conglomerate cabinets like this. There are also other states that really work more at the county level, but those would be big states. New York does that, Texas does that, California does that. Our closest state is Ohio, that is a county-based system. We're a state-based system. And it would take me too long to fully explain that, but I'm happy to do that one-on-one. But I just want to say that within state governments, we are fairly unique in how we approach how we do these programs. A lot of times Medicaid, and you'll see, is so big that it sits by itself often, or sits with finance or something like that. But because Medicaid is such an important part of all these other programs, again, I feel it makes sense to have that a part of an individual cabinet. Then our central office functions, again, you can see all of these pieces. Many of them are here today. It is, again, these are the folks that really kind of serve to support these other departments. And that's a good way to think about that. Go to the right way. So, as I said, the cabinet's huge. And when you think about how many people are employed, how many different agencies and branches there are, what kind of the impact is around Medicaid. And when we say 1 in 3 folks receive their health care coverage through Medicaid, that is true. volunteerism hours. I'm going to get into a lot of these pieces later in more depth, but this just gives you sort of an overview. We have for you, if you are interested, kind of the impact on the county level, and that's the way we've been able to break it down of programs like Medicaid and TANF and SNAP and childcare. So if you are interested in that, we have those for you to say, what does that look like in my individual county? How much of SNAP, and I like to say SNAP, goes to your grocers, your local grocers. Medicaid, there are no benefits really that go to individuals. It goes to healthcare providers. So what is that impact on healthcare providers as we go through those processes? So most of these programs serve, and we talk about providers or grocers, a lot of this funding then goes to them. So I just want to make that point as well. So within the Secretary's office at this point in time, the Office of the Inspector General really does the healthcare survey, licensure, reviews all of that. So they're the ones that do the inspections of nursing facilities, as well as childcare, hospitals, basically the healthcare side. This is the group that does the vast majority of inspections. We also have a special investigations unit that when we get some very specific things, either around some of the things that we're doing, we do have a group that can do some what are called special investigations. So think of the Inspector General's office, and I am going fast, as this is the investigatory arm of the cabinet. And most of that occurs through the Office of the Inspector General. Medicaid, and again, you'll get a much longer presentation on this. When we did this slide, it was 1.6 million folks who were enrolled in Medicaid, and what was that, 4 or 5 months ago? The number's now 1.7. So that 32,000 providers, again, what I like to say is without Medicaid, even though we can have concerns about the level and the reimbursement level of Medicaid, and how sustainable it is for all of our providers across Kentucky. Without Medicaid, we wouldn't have any. Without hospitals, nursing facilities, childcare, a lot of that basic infrastructure, not childcare, is supported by Medicaid. So just kind of a little overview of that. Medicaid is one of the more complicated programs. You'll have a much longer presentation on that coming up right after me. But know that when you see that, again, $14 billion with a B of what flows through Kentucky, and really, again, the way I like to think about it, goes to providers of Kentucky. That's who receives this funding. Community-based services, that's Child Protective Services. It is our eligibility programs. They do all of the eligibility pieces. That's SNAP, that's child care, that's TANF, and then Child Protective Services and Adult Protective Services. So our social workers are there, and we continue to have tremendous challenges on attracting folks to be social workers. I talk about social workers as like the everyday heroes that you don't read about in the newspaper. They go into the toughest situations, sometimes where law enforcement doesn't want to go, particularly if it's domestic violence or child removal. It is a tremendously stressful job. One of the reasons I came back to the state of Kentucky after working for Louisville Metro government for a little bit was I knew that we had social workers and we had never addressed really secondary trauma, what that experience is of actually being a social worker, and really trying to figure out how to support and say it in a way that makes a difference and makes their lives easier. Much, much easier said than done. There are issues within CHFS, within DCBS, that roll back 20, 30 years. Eric Clark was briefly commissioner of DCBS and did a fantastic job. And really, I used Eric as an example of you don't have to come from the same place in order to be an effective leader of an organization like DCBS. So that's the important piece in DCBS. We have that number's a little less than that 9,100. Again, this was from the CHFS task force presentation, but thousands of children whom we are saying to them, we are going to do a better job than your biological parents. All too often, that is not the case. That's been documented across the country. It's been documented here. So what can we do together to make this better? And I'm pledged to do that. You all have been pledged to do that. I wish Senator Adams were here because she sponsored Senate Bill 8, which really helped how we think about abuse and neglect, really trying to say poverty is not neglect, which our statutes say. It's, I think, one of the reasons we've been number one in child care abuse and neglect, because sometimes we equate poverty with neglect. And so trying to work our way through that, what does that mean? How do we make sure that we're supporting families and children so that they can stay together? I can't imagine turning 18 and not having any parental support and family support. It boggles my mind that folks are able to do that. But unfortunately, we see negative outcomes from that all the time. I can go on and on about that. We also provide SNAP assistance for hundreds of thousands of people across the Commonwealth. So those are the kinds of programs that we have. We tend to think of these programs now, and we try to say them while I'm talking about SNAP and TANF as prevention programs. Supporting families hopefully will help them stay together, and some of these minimal financial supports assist with that. So when we talk about public health, this is, as you know, we've come through COVID, but there have been years of underinvestment in some of these local health departments. Those of you, I hope, will talk with your local health department directors. They're fantastic people, and they've been strong folks for several years now. And so, Chairman Moser, thank you for your legislation on public health transformation, trying to get public health out of the direct service role into one more of a population health and prevention role, so that we can really work on population health and leave the individual health pieces to healthcare providers. So really working on that. The last General Assembly actually put some funding for that. Again, very appreciative of that and appreciative of the partnership, because it is, when we work together, we get good outcomes. And so I always welcome that opportunity. Public health does so many things that you don't think about. I call it the 4:30 on Friday call, when there is a group of kids that had been touring someplace, and there were bats in the belfry of the place that they were touring, and we have to go through all sorts of rabies protocols. It always happens. Radiation that comes through the state, we have a radiation branch. They know and get notified, and oftentimes accompanying those kinds of shipments that go across the state. It is, local septic systems with local health departments, the folks that do the restaurant inspections, those who are in your local health departments. It's a little mind-boggling, the breadth that public health covers. So in the recent floods, the water testing that they were doing all across eastern Kentucky, making sure that there were tetanus shots available. These are the kinds of things that public health does every day in our local communities. So if you've not had an opportunity to talk or visit with your local health department director, I encourage you to do that. You'll be amazed by everything that they do. And I am also a Dr. Stack fan because I like his hair. So behavioral health. These are your local comprehensive care centers is one way that's one piece of behavioral health. But this is the group that works on substance use, behavioral health, developmental intellectual disabilities. This is the group that really works on those issues across the Commonwealth. I think next week you'll have a presentation on CORE, which is the really in partnership with a lot of folks, but it's part of the substance use effort, and the substance use money that comes through the federal government flows out through this department. Oftentimes it's in concert with folks like Van Ingram, who I think you'll have next week, and others, and you all, as we try to address what has been an incredible scourge of opioids. Certainly we had a corporate issues there that have driven us to a place that's horrible, and you look across the Commonwealth and you see that, and now we're seeing the impacts of fentanyl. Just incredible numbers of overdoses resulting in deaths. So how we work through that, we do talk about harm mitigation. How do we make sure people stay safe with Narcan so that they can live to get into recovery? So those are the kinds of things we try to work on the substance use side. And then folks with severe mental illness, again, sometimes you see some of those folks on the streets. How we engage, how we work with folks like that, because it was really, I'm going to bring up what we talk about throughout the cabinet, but I think it's particularly poignant here. Individuals who had severe mental illness 20 years ago, the clinicians didn't believe that recovery in any way was possible. Just wasn't possible. Well, families spoke up and individuals spoke up for themselves and said, no, you've got this wrong. Recovery is possible. Well, listening to that voice of lived experience is what we call it. That altered really how the treatment regimen and the expectations for individuals who have severe mental illness, that indeed recovery and life perhaps on a different trajectory is possible, but a normal life can occur. And so this is something that nobody believed until the families themselves and the individuals themselves spoke up and said, yes, we can. So I use that as an example of why listening to constituents, as you well know, oftentimes they're closer to what's happening in local communities and local neighborhoods, and they can oftentimes provide us insight that is important for how we practice. Aging independent living, you just had Commissioner Elridge up here speaking about what she does. Senior meals is the one I always like to start with. When I was with Louisville Metro Government, I was a community action director, the only governmental one in the state, and we had senior meals. And those programs are so very important because what is a challenge is social isolation. And so in our seniors that maybe don't have transportation or can't get out, having the opportunity to get senior meals or in a congregate setting at an adult day center, these are really important lifelines for our seniors. In the past several years, we have eliminated waiting lists for seniors and senior meals, some of that due to some of the extra aid that we received, but right now it is due to additional funding that the General Assembly provided us to make sure that we don't have waiting lists, because a senior on a waiting list who needs food just shouldn't happen. Department of Aging and Independent Living, we recently established an Office of Alzheimer's and Dementia. I said this at the task force. My mother suffered from that, passed about a year ago, and so it's kind of near and dear to my heart. We need to understand what the resources are. The Secretary of the Cabinet for Health and Family Services and struggled finding resources and struggled making the connections about now which one am I going to and who am I talking to and can I get this person in and how do I pay for them? I mean, it's daunting. And so having somebody that can help answer questions is really important. And there are some private brokers out there, but we need to provide that support as well. And so the Office of Alzheimer's and Dementia is really, really working on this. The other big piece that we have there, and I'm skipping over several big pieces, but another one I want to highlight is the guardianship program. So those folks who can be declared incompetent and assigned to the cabinet, right? Because you can be declared and have a private guardian, but we're the public guardians. So we're sort of your last stop. I hate to say it that way, but it's true. So we have more and more folks who are in our guardianship program who are responsible for financial, case management, make sure they're safe. This is a program that has grown over time. The previous administration started down the road of making that piece that was healthcare related in the guardianship program Medicaid reimbursable. And so we've been able to expand the program, start to bring our caseloads to a rational level for our guardianship program. We've got a long way to go in DCBS, but it has it really has made a difference for the folks we're trying to serve. And I think it does make a difference. A lot of times those programs kind of get a bad rap, but they're really important to support individuals and communities, and the guardianship caseworkers also do a fantastic job. Like social workers, sometimes they get into situations and with individuals who are not completely stable in a way that is safe, and yet they go and they do their job. So it is something that I always like to lift up in the cabinet, that we walk into bed and tough situations, and yet we do. That's over 1 million meals served. I mean, it is also through your local AAAs, your area aging on living. I'm going to get that wrong. Occasionally I get my initials wrong because we use so many of them. But through your local area development districts, there's an aging component. They're also really an interesting group to get to know. So what they do every day, and a lot of times the local communities respond in local ways. So it's a really interesting program to see across the state, and I'm pleased with some of the creativity that we've been doing there. Within the reorganization bill, there's an address of Adult Protective Services, which sits in the Department of Community-Based Services, and Guardianship, which sits in Office of Aging, and that's a part of the reorganization bill that's coming forward. And then a personal favorite of mine, I've been over that program, did I? So there's several that we've gone through that I've been over at one point in time. But Family Resource Centers, I know you all know this program, started in the 90s. I was briefly over this program. This is a great program. This is about social services in schools. And this was placed in the Cabinet for Health and Family Services. As you see, a lot of our programs, it relates to a lot of our programs. And so it really is a great bridge between the Cabinet and education. And Family Resource Centers, again, during the tornadoes, during the floods, they were able to provide support for their local communities. With the tornadoes, had partnerships with making sure that folks were safe. Were able to gather what was coming into communities in terms of resources and individual items, sorts of things, and really kind of assist the community and be a local hub for that community to get some of that actual physical assistance. They do a lot of different things across many different schools. We're in most of the schools. It's based on the amount of free school meals. That's the per pupil. And again, through the collaborative work of the General Assembly, we've been able to increase that per pupil up to a point where I think it really is more sustainable within local school districts. So again, just another example of how we can partner together. Serve Kentucky, another really great program. I like to say we have really two really just kind of pure good news programs in the cabinet, and that's Frisky and this one. So this group goes out and solicits volunteers. They've been going out, the Serve Corps, where they go out and they've actually been assisting in flood cleanup and tornado cleanup. Folks can come into this program and get stipends and begin to get the work experience. If you all ever get the chance to either the kickoff for Serve Kentucky and AmeriCorps or their graduation ceremonies, they are fantastic and a lot of fun, and please don't miss them. Joe Bringardner, who is currently over Serve Kentucky, we call him the most interesting man in the Cabinet for Health and Family Services, but he has tremendous energy and is a great advocate for the program, not only locally here, but nationally as well. Child Support Enforcement, that is the group that actually works with local county attorneys and collects child support across the state. A lot is collected. We had whole discussions about challenges with arrearages, which is a real thing. But it really is, at its core, making sure that children get the support that they need and get the financial support that they need. I'm going to go back one. I see. There's a second program in this department, and it is disability determinations. It's a unique program. We're a contractor for Social Security. So those folks who get disability Social Security, it's this group in Kentucky that goes through the eligibility process, reviews their cases, determines if they're eligible or not. I will tell you, this program is considered to be the best in the Southeast, one of the best in the country. We've worked long and hard on getting caseloads down. We've increased some of the salaries and recruitment in disability determinations. They're really doing a great job, and they are being recognized really across the country, and particularly in our region. It's called Region 4. It's the kind of the Southeast, as really being a leader there. When we presented to the task force, we weren't able to really talk about this program. So I wanted to give a little bit of kudos to these folks because they do a very good job. It's the Social Security Administration, the way that we contract is, like I say, unique. It is very, how to put it, it's the only program we have that is really truly 100% federal in terms of all of the everything about the program, from the person that runs it to everything that we do. It's 100% federally reimbursed. We use a federal program. Like, they don't even use the state email system. They have to use the federal email system, and it's because they get into people's Social Security. So the privacy requirements around this, we actually have to run a separate data line, like physical data line, into our disability determination offices, because we can't even run our state line and the federal line together. So I mean, the way that it is separated is makes it unique. I also used to be over this office. I was also over both the offices we had passed. The Office of Children with Special Health Care Needs is really aligned with public health. It has been. It's been in public health. I think in the 70s it's out. So I think that's part of the reorganization bill, one of the recommendations there. It is more direct services than public health. We run clinics. My favorite clinic was called the Cranial Facial Anomaly Clinic, where you had neurologists who were working with dentists, working with physical therapy, occupational therapy, a whole group of folks, plastic surgeons, who come around a child who may have, before they're 18, 20, 30, 40 surgeries because of either a cleft lip, cleft palate. One of my favorite days when I was working at the commission was when we'd look at a child and see the transformation that would occur because they're going through our clinic. And so those clinics, what they do is they bring together a group of practitioners, and those, instead of having to go to 17 different appointments, they're usually able to get a lot done within that one appointment at the commission. The biggest thing, probably the most, I think, impactful thing we do is what we call our EDDI program, which is Early Hearing Detection Program. And so in Kentucky, we have a requirement that before a child leaves a hospital, they get tested for hearing. If they fail that initial test, then they go for further audiological screening. And commission offices, we employ audiologists, although we are having trouble hiring audiologists. But we have hearing booths. We provide that service to kids. And really, we're very good because a lot of states have a lot of folks who are lost to follow-up, right? In other words, they get that hearing test, they fail the hearing test, and then we don't see them until they enter school, right? We really are good about making sure that those folks get hearing tests so they can get into early intervention. And so that's a program that's at this little commission. I call it the little commission. And they do a very good job with that. So we partner with a lot of different folks across the Commonwealth on that. So I've been talking a lot and gone through a lot of different things, and I honestly just scratched the surface. And I wanted to do this as quickly as possible. But again, what I would like to invite any of you to do, please reach out. I'm happy to meet at any time. If you have specific programs that you are interested in, I'm happy to go through them as well. And what I will tell you, and I hope, again, the chairs know this, I won't shy away when I think it's something we're not doing right. I will tell you when I think we're having challenges. I think, as I just did with social work hiring and retention, those are real challenges. We are seeing, as children come into our system, we're not, what I've said before here is that we're not seeing more children who are suffering from abuse and neglect, but the abuse and neglect that we are seeing is more severe. And you could get any partner up here, I think, who would say that. You know, when we have challenges, we work together, and when we work together, we make a difference. So I think when we've done that, and we have done that a lot, I know we've made a difference.
And we will continue to. And I really appreciate the overview you provided. I hope that our committee members can appreciate that when we had our task force, we met 6 times. And not to be redundant, but bear in mind again, this is 93 agencies with over almost 7,000 employees. You mentioned a $19 billion budget, but that really doesn't factor in the Medicaid as well. That's another just $15 billion. The state's portion is about $2 billion, so it's a massive cabinet. And I want to thank Secretary Freelander for the unparalleled access he gave us to his cabinet. His folks met with us, and what we learned very early on is this is a big task to undertake. And I'd like to cover very quickly what the recommendations of our task force are. There's only 9, so this shouldn't take us very long, and then we'll entertain questions from the committee members. But again, want to thank you for your cooperation. It was tremendous. And I'll probably start with our last recommendation first because it became the most obvious, and that being that we can't do this in a year's time. So one of our recommendations is that the task force will continue at least into 2023 and possibly even beyond that. But I want to emphasize again, when we did this reorganization, its intent really, let me find my notes here. The objective of our task force and the recommendations you're going to hear is not to reduce the number of departments, divisions, or programs in the cabinet, nor is it to eliminate invaluable programs and services. Rather, the objective is to streamline programs, reduce bureaucracy, eliminate redundancy to create efficiencies within the cabinet and state government as a whole. And I would add increased accountability for everyone. And I think that helps all of us serve our constituents better. But with that, the first recommendation, as I mentioned, was to continue the task force through 2023. Second, this bill was filed. It's Senate Bill 48. It's out there. We intentionally filed it very early in the session to give folks a chance to review it and make their comments and so forth. So I would ask Secretary Freelander for his initial assessment of these things. I don't expect you to be able to give any kind of detailed explanation as to whether you agree or disagree, but just get your good reaction to this. But first was the Child Support Enforcement Program, which we had a lot of discussion on. And the reason we had that discussion in great detail is that at that time, 56% of the total amount of current child support has been collected, which I guess the converse of that is almost 40-some% had not been collected, and which represents 44%. And present, we are at a total of $1.4 billion in arrears. So there's opportunities for improvement there. And specific to Jefferson County, that $1.4 billion, $89 million is in Jefferson County alone. So our recommendation with regard to this program and to the legal nature of it is that we move it to the Office of Attorney General. And we think that the impact of this program can really change children's lives in the future. And it's also recommended that the determination of disability we'll move to Education and Labor Cabinet. But I'd ask you first to speak to the Child Support Enforcement Program and our recommendation.
Well, of course, I will take a look and we'll have more of a discussion about it, I'm sure. What I can say about the Child Support Enforcement Program is it's a big program. There are quite a few employees. With the Attorney General's office, I think it would maybe almost double their size. Working with county attorneys is oftentimes a challenge. And I think part of the recommendation, if I remember it right, was maybe even looking at privatization. Do I remember that? I don't know if I haven't read 48 all the way through yet.
Yes, sir. That was part of that recommendation.
Okay. So pretty much my reaction to all of this is it's worthy of discussion. You have the task force looked at spots and programs that I think are worthy of review, and is this the right way to do it? Is it right in the cabinet? Not giving a yay or a nay, but certainly this is something that we should look at. I think for the Attorney General's office, this is how to put it. Well, I don't know. It's almost like be careful what you ask for, but you and I have had that discussion. It's a tough program. It's a tough program.
Well, certainly is. And, this was not just a whim of our committee.
Right.
I think the foundation of this was the audit our state auditor did back in 2019. And it was, for want of a better term, a very damning report that we could do better. And we'd like to see some substantive changes. And we think the best way to do this is to move it to the area that has some legal teeth to it. So that's the basis of our determination. Second part of that was the disability termination services. Move that to Education and Labor Cabinet to obviously try to impact workforce in Kentucky, which we still struggle with.
Again, this is a program that is pretty isolated in terms of how it works within the cabinet. One of the things we talked about was the way that it's how we do our accounting, our inner accounting, and it's how we kind of fund some of the central functions. This being a 100% federal program, there may be some small implications, and we'll communicate about that.
All right, thank you. Third recommendation is the Office of Children and Special Health Care Needs would be better served under the Department of Public Health. It's a director's position. It certainly aligns with public health. So, with your nodding, I assume that you are in agreement with that.
It's been there in the 70s, I think, was the last time we were there. I still consider myself as being there. And so I think the only challenge there that I see is that they do more direct service than perhaps the public health transformation piece. But again, right thing to look at.
Thank you, sir. Next recommendation is to move the Family Resource and Youth Services. When we looked at two different options, one being that it could be placed within Education and Labor Cabinet, and the other option that it could go to DCBS or Department of Behavioral Health. And the bill, as filed, has it going to DCBS, but that's not my preference. I'm going to submit an amendment to that bill to move it to Education Workforce Development. And my rationale for that, it goes back to the original intent of the program to help our educational system by reducing truancy and absenteeism. But I think it has an added benefit that it can help working families, and certainly that goes back to workforce development again, but also focuses on accountability of the system. And so one of the earliest questions that I have is how do we ensure accountability is in? And these folks do a fantastic job, and I appreciate Melissa Goins' testimony as well. And she even acknowledged, she said, we can go anywhere because we're going to do a great job, and we know we will, but we think this gives new opportunities for the future. Next recommendation is the Office of Ombudsman Administrative Review and the Office of Inspector General be separated from the Office of the Secretary, and protocol developed to ensure independence of its operations in order to uphold public integrity and confidence.
And they've been out of the Secretary's office and in the Secretary's office before, so I understand what you're saying. What I think I've said to you is this: I've been in the cabinet when I think their being in the Secretary's office was a problem, and I've been in the cabinet when when their being there didn't cause a problem. So it really is a structural decision.
Thank you, sir. Next recommendation is require Department of Medicaid Services, Department of Aging and Independent Living, and Department for Behavioral Health to identify and eliminate redundancies and barriers to administering the 1915C Medicaid waiver programs and issue a report containing finding recommendations to the Legislative Research Commission by December 2023. And I think we've all tried to wrestle with the issue of the number of people on the waiver program, and we know that we're have a great disservice to many of our constituents because we haven't been able to fill those slots. Next recommendation is require the Office of Human Resource Management to work with the Personnel Cabinet to identify systemic barriers and redundancies that are preventing an effective and timely hiring and outboarding process for prospective employees. And as part of our discussion, we realized that we had kind of created a department within a department to hire people, and it was creating a barrier to getting people on board quickly. So that's why that one was presented. The state guardianship program with the Department of Aging and Independent Living assists vulnerable adults, which can be administered as an extension function of adult protection services within the jurisdiction of DCBS. And last, I've already, I think I made mention to, is that given the growth of the Medicaid program, as you acknowledged, I was surprised by that 1.7 million people that are there in a $15 billion budget. But because of that, increased demand for public assistance and social and human services, Task Force acknowledged the need to reevaluate the committee structure of the General Assembly in order to adequately serve the needs of Kentuckians. And that was a driving force as to why we now have health services, and we have another committee of family and children services. And so we've taken our action there. But any other comments with regard to that?
No, I applaud. I actually applaud that. Oftentimes, when it's the combined health and family services, it's because Medicaid's so big, it gets all the attention. So I really think that that's great. The only other thing you didn't ask me about, I think, was family resource centers and volunteerism. And the only thing I have an emotional reaction to that because there are only good news.
You noted that during the task force meeting, and we all acknowledge those are really feel-good programs, and I'm sure every cabinet would like to have them as a part of their cabinet, but just trying to realign goals and accountability. And just again, personally, I think it needs to be an education in the labor cabinet, but there'll be ongoing discussion about this. But of all these recommendations, I believe the issue with child support are probably the most pronounced in terms of what we need to address, because there are tremendous problems. And I'd like to share our task force report with the rest of the committee members so you're familiar with it and with our findings as well, but some significant issues in that area alone. But with that, Chairwoman Moser, we have questions? Representative Weber.
Thank you, Mr. Chairman. Secretary Friedlander, thank you for the presentation this afternoon. I want to talk for a moment about the electronic health record system. A little bit of background for new members on this committee. That was a cabinet requested upgrade to support all the agencies within the cabinet. Last budget process, we allocated $50 million for that system. Two questions here. When will the cabinet issue the RFP for that system, and what is the timeline for its implementation?
Those are two good questions. I know we've been working on the RFP. I don't believe it is out yet, but I expect it to be out probably within the quarter is my guess. I'll have to get back to you to make sure I have the right time frame. You're really looking at an implementation of, best case scenario, I think 18 months.
18?
Yeah.
Right.
And I think I'm probably optimistic on that. But
okay. All right. Thank you.
Senator Carroll, you have a question? Comment?
Thank you, Mr. Chairman. Mr. Secretary, you said something a few minutes ago that kind of caught my attention in relation to child abuse and neglect. And once the definition changed with dealing with poverty, do you all have any numbers? Do you have any idea what the impact of that will be?
I think we're going to have to watch it over time. Okay. I don't think we know exactly.
So there's been no way to track that up until now?
No.
Okay.
No. And I think, well, you've already seen, if you look, we've moved out of the number one position, and the country's still way too high. any abuse and neglect is too much. But I think that some of that movement may have something to do with that as well. That's got to be adding to it. I'm not sure that change, the numbers that are being reported now, would have been impacted by that change. But I think it's something to watch. And I think as you see what happens across time, the next couple of years, as where Kentucky ranks, I think you're going to see some. Hope you're going to see some change that is actual change, but you're going to see some change because we're changing definitions.
Thank you, Mr. Chairman.
Chairwoman Mosier, you have a question, comment?
I do. Thank you, Mr. Chairman. Thank you, Secretary. And I just have a couple of comments. I would really encourage all of the members, especially new members, to get to know Secretary Friedlander and the various commissioners with whom we work. It is critical that we get to know who works on what, because we will have questions, you will have questions from constituents, and the cabinet is a wealth of information. I have a regular meeting, and it is it's a great way to touch base and really talk about some of the issues that are important to not just our constituents, but on a more global level, to really talk about some of the issues that affect our policies. So they are great. Everyone I've worked with at the cabinet has been really wonderful, very helpful. Most of you, and many are in the room today, have just a lot of institutional knowledge, and we can really learn a lot from everyone at the cabinet. And I have a second comment that, and I know that you've touched on the healthcare worker shortage. We've all experienced it. We discuss this often, and the social worker issue in the cabinet. I mean, it just keeps coming up. We've given raises. We are acutely aware of the situation when we talk to our residential providers of care for children in out-of-home placement. So, if there are any recommendations from the cabinet to us, if there's some way that you think that we can help, I know that this is a critical problem in my area. We are having difficulty hiring individuals, paying individuals, reimbursements are low. So this is an ongoing conversation. I don't want to necessarily ask you for numbers today, because I know that this is something that waxes and wanes, and retention and recruitment are an issue. I know that Commissioner Straub is leaving, and that we're getting someone new, and we'll need to get to know that person. But I know that there were some programs and projects that she was working on to help with retention. Do you have any comments just broadly on the situation with the social worker issue?
Sure. And Lisa Dennis will be the acting commissioner coming forward. Years and years of experience within DCBS and some lived experience as well. Yes, we've tried salaries. We're trying different recruitments. We're actually going to hire a recruiter who will actually go out to the schools of social work. We for years, because it was such a hard job, some of our schools of social work and some of the professors there would say, yeah, the last place in the world you want to work is DCBS. So we are trying to turn that perception around. Couple of things that we've done, there have been social workers who've had guns pulled on them, right? And we didn't have any mechanism to allow them to have time off and really take the breath and have some time to recover. We've just, like within the past year, worked that out with the personnel cabinet, what that looks like, and it was due to a lot of advocacy on the part of social workers. One of the things that it's just a brand new experiment, but as we looked at why people left, the second reason was how difficult it was for a social worker just out of college to walk into a courtroom without any representation. That was just daunting and intimidating. So we're trying to figure out how do we provide some more support there. It's more in the idea phase than the implementation phase. But as we move forward with that, I'm going to be happy to bring some of that back. And then it is, how do we provide support? What does that look like? We are down hundreds across the state. So we've got a lot of work to do. And what I would say, anybody watching this who would perhaps want to come work for us, the fact that you can make a difference in a child's life any day that you wake up and come and work for the cabinet and make that kind of difference for a child and a family, I hope that that's inspirational for folks to come to work for the cabinet.
Secretary, just a couple of last comments. I'll let you leave so we can move on the agenda. But I failed to mention that Serve Kentucky, which you talked about, it certainly falls in the same category as the Friskies in terms of kind of feel-good programs. Is our recommendation is to move that to education workforce development as well, because we think it's a good channel for future workforce for Kentucky. So,
Thank you.
Last thing, I just want to follow up again on this Child Protection Services. It's very disturbing situation. I made reference to the report that Auditor Harmon did in 2019. Report of Kentucky's Child Support Enforcement Program, and he specifically cited that the lack of monitoring and oversight of the department. This is 2019. Have there been any substantive actions taken to try to address that particular component of that report?
I think we're working on it. I think the committee hearing that you held got some folks' attention. I will tell you that I've reached out to some of the county attorneys that were called out kind of pretty specifically and said, you got to perform. So I believe that you put them on notice, we put them on notice, and I think this legislation will put them on notice. If we don't get better performance, something dramatic is going to happen.
Well, I think about that same time we had a Inspector General's investigation into Daviess County.
Yep.
And apparently there's some significant problems there, and rumor has it that a whistleblower involved and was demoted in his position. Is there something that's changed the culture there, or is this just kind of an ongoing situation that we need to look further into?
I'm not really aware of that, so I'm not aware of that piece.
All right,
Demoted within Daviess County or within the state system?
Daviess County.
Oh, okay, yeah. I'm not aware, but that doesn't mean, that didn't happen within a county system.
All right, thank you. No further questions, comments. Appreciate your participation. I'm sure you're going to hang around for this next presentation as well. And
I'm planning on being Vanna White. I'm going to move over a chair.
All right, thank you. This next portion is a update and overview of the Kentucky Medicaid program. I may have already stole your thunder by talking about the number of people and the size of the program, but just to put in kind of historical context, is when I came here in 2017, the Medicaid budget was $10 billion at that time, and we had significantly fewer participants. And I've said 1,000 times since then that I thought in 2016, that's as large as the Medicaid budget should ever be. By improving the health of our population and getting people back to game of employment, we can save the Commonwealth a substantial amount of dollars. But here we are, 2023, 24, and looks like 1.7 million of our population is on Medicaid, and we're going to have $15 billion. So with that enthusiastic intro, please identify yourself for the record and feel free to proceed.
Thank you. My name is Veronica Judy Cecil. I'm the Senior Deputy Commissioner for the Kentucky Department for Medicaid Services.
I'm Steve Bechtel. I'm the Chief Financial Officer for the Department for Medicaid Services.
And let me say, so Medicaid Commissioner Lisa Lee is unable to be here today. She sends her regrets. And she is very much, as we are looking forward, there are a lot of familiar faces, but we're looking forward to meeting and getting to know the other members. We are public servants. We are here to serve. We want to work with you on the program and help you understand it. So we look forward to that as we go forward. This is a Medicaid 101, so I have 3 hours. Is that correct? To touch the surface. Medicaid is a very large and complex program, and we're going to do our best to really highlight, obviously not get into too much detail at this point, but happy to come back and or meet with you all individually to talk more about programs you may be interested in. As we have spoken, approximately 1.7 million. We have grown. A part of that is as a result of the pandemic and the public health emergency and continuous coverage that's been mandated for us. We'll talk about that a little further on into the presentation. Over half of Kentucky's children are covered by Medicaid. We have both traditional population that's mandated, that we cover, and we have other optional programs like our expansion population. We like to show, because we talk a lot about federal poverty level, and that is what definitely is, income is one of the components of an eligibility requirement. And so 138% is our adult expansion. That's the max of income that somebody could have. We're talking $18,700. We are here to serve the Medicaid member. That's the reason the program was created, but we can't do that without providers. So we do have over 69,000 providers. These are host, the Secretary mentioned several of them, nursing facilities. So we have a bunch of facilities. We have individual. It goes anywhere from physical health to behavioral health. So a very wide provider type. We have over 90 provider types in Medicaid. I want to emphasize that we are a federal state program, so most of the requirements come down from the federal law and regulations. We are created under the Social Security Act, Title 19. That's where primarily our requirements come from. So we do have to comply with those. Our regulatory authority or agency is the Centers for Medicare and Medicaid Services, CMS. You'll hear us talk about CMS a lot, what CMS will let us do, what they won't let us do, things that we have to get approval for. So you'll hear CMS quite frequently when we're talking about our program. I also want to just note, a couple of things. Just note, there is a difference between Medicare and Medicaid. So Medicare is a federal insurance program. It's generally for those age 65 and older. We are, as I mentioned, federal state, so the state does pay a share, but the majority of our costs are covered by the federal program, by CMS. So we do have what we call dual eligibles. So just to make it even more complicated, there are people who can qualify for both Medicare and Medicaid. So we do have some classifications that fall under that. But Medicaid really is the kind of go-to state program that can cover people and services that aren't covered anywhere else. Not covered by Medicaid, not covered Medicare, not covered by commercial insurance. And so that's when a state Medicaid insurance, state Medicaid agency and program comes into account. And when you see one state Medicaid agency, you've seen one state Medicaid agency. Every state has different programs and populations and services that they cover beyond what's mandated. So while we may cover something, another state may not. So you have to keep in mind that when you do compare Kentucky to other state Medicaid agencies, that there are some differences, and you have to take that into account. So very quickly, our department at a glance, we have 7 divisions now, and we did a reorganization last year, and the reason we did that is because we wanted to refocus the program to where we think the priority needs to be, and that is the creation of a Quality and Population Health Division. We previously had quality as part of our managed care oversight and decided we needed to separate that out and focus specifically on quality. So this is, again, a very new division. We are starting to staff up that division and start looking at quality and metrics and how can we improve the health of our members. And that includes working with providers on value-based payment programs, trying to drive and incentivize outcomes through various types of program. I would like to say that we have been able to, our rate of vacancies has slowly declined. And I know that's due to the salary increases the General Assembly budgeted for us and the support of Governor Beshear. And so we've been able to actually fill vacancies we had not been able to fill in a long time. And we've been under-resourced for decades, to be honest with you. So we are able finally to staff up and really have skill sets and experience that we need to help drive outcomes. So this is the 26 covered populations. And within those 26 populations, we have 39 types of assistance. And what all that means is that each of these have their own eligibility requirements. It could be age, it could be income, it could be resources. And so it's very complex and very complicated. And so we have to make sure our system is able to, when somebody applies for Medicaid, is able to determine appropriately and accurately whether or not they qualify. So it can be a challenge. And then again, I mentioned on the right-hand side, you see we do cover some Medicare populations. Those are our dual eligibles. Generally what we cover are their premiums or their cost sharing. But again, very complex program. Covered services. So we have what's called a state plan. Our state plan is the approval from CMS that both make sure that the services we cover, who can provide that services, and what we pay them is approved by CMS. So the federal law requires services in Medicaid to only cover medically necessary services. And there are ways to determine that, but primarily there's criteria that has to be met to make sure that the service is medically necessary for that person. We do only pay for services, so we don't pay for room and board, and a lot of people don't understand that. So we're only allowed to pay for health care services. So you may see that we're covering services in a residential facility. We're not paying for the room and board there. We're paying for the services that are being provided within that residential facility. We also, children, there's another provision in federal law called EPSDT, and you will hear sometimes a lot about EPSDT. That stands for Early and Periodic Screening, Diagnostic, and Treatment. What that does is requires us to pay for any medically necessary service for a child, even if it's not covered in our state plan. So we have providers that are enrolled specifically as an EPSDT provider, and they may be providing something that's only available to those children that's not available to the rest of the population.
And may I, just for a second, because EPSDT is such an interesting history. It really came out of when, really the draft, and so few adults being physically able to be drafted because of all sorts of physical health issues. So this EPSDT program was put in place that whatever the child might need from a medical perspective, they should receive, but it was really about national defense and making sure that our population was healthy enough to serve. So it's an odd piece of history, because it's like, why does this program exist? And sometimes when you trace these programs back, it goes back to things like that. So I just wanted to, sorry for the little interjection, but I just think it's an interesting piece.
appreciate that history. As the Secretary mentioned previously, we pay providers, and we have, again, our covered services range from physical, preventive, behavioral health, substance use treatment, so just a wide range of the services that we provide under that. Wanted to just talk briefly about a couple of other things. Non-emergency medical transportation. So these are if an individual needs transportation to a doctor's appointment, to the pharmacy, they can get, if they don't have a car, they can get access to that transportation through this program. The Transportation Cabinet Office of Transportation Delivery is who administers that on our behalf. We have a contract with them. School-based services, so you may be familiar with IEPs or individual educational plans. If one of our Medicaid members has an IEP, we are able to cover the services, the medically necessary services to support that child in the school. We work with the Department of Education for that. All of the claims and the administration of that comes through the Department of Education. We now, though, thankfully also have available what's called expanded care, and schools now, where they were limited to providing services within the IEP, they now can provide services outside the IEP to any Medicaid child. And so we have been working on encouraging that. It is something we just launched in 2019, and then the pandemic hit, and so it kind of slowed adoption of that, but we're going to be working and trying right now we're working on a plan to work to reach back out to schools and make them aware that this is available. That includes behavioral health, preventive care, so we're excited about refocusing efforts around that area. The other is the Health Access, Nurturing, and Development Services, otherwise known as HANDS. This is through our Department for Public Health, and this is a voluntary home visit program for any new or expecting families. So we go and we help parents understand what's coming, what they may need. And then the other is First Steps, and that is also administered by the Department for Public Health. That is for children from birth to 3 that might have a developmental delay. And so they go and they help the child and provide support to the child and the family around services to help with that developmental delay. This is a snapshot, and hopefully you all can see it. I know it's kind of small. But the state represents the percentage of Medicaid members per county. So for instance, if you take Franklin County, it's blue. The percentage of the population on Medicaid is from 21 to 40%. On the right is our demographics, so by race, by gender, and by age group. I will note that race is not a required field for somebody applying to Medicaid. So what this shows is the number, is the percentage based on those who reported their race. We're not allowed to make that a mandatory requirement. But as you can see, a little bit more female than male, and a little bit more adult than child, and then our elderly population. And this is Kentucky Medicaid enrollment by plan, and by plan we mean managed care organization, and we'll talk about that a little bit more in a minute. We do have 6 managed care organizations, and then what's FFS there is fee for service. Those are the ones that that the department takes care of directly. The others, the 6 MCOs, are the individuals are in managed care, so they are the ones that manage the care of our members. So as you can see, WellCare has our highest. The lowest there is United. They're a new entrant into the Medicaid program in the RFP that was issued in 2020. So fee for service versus managed care. I will say 41 states have managed care. Most states have moved that way, and the primary reason for that is budget predictability. Managed care organization assumes the risk, so the state pays the managed care organization, and they have to provide services within that payment, and they're at risk if the cost exceeds the payment. There is, for a managed care organization, a minimum medical loss ratio. So you'll hear us talk a lot about the MLR. What that means is that in Kentucky, which we have one of the highest, it's 90%. So a managed care organization is required to spend at least 90% of what they receive on healthcare services. If they do not, then we have within our contract, we claw back the difference if they do not spend that. So the state in fee-for-service, the state pays the provider directly. In managed care, the managed care organization have provider networks and they pay the provider. The population for fee-for-service is generally the age, people in long-term care are part of the fee-for-service in Kentucky, as are the intellectually and developmentally disabled individuals that are in our, what we'll talk about shortly, our home and community-based programs. So all of those remain in fee-for-service. The rest of the population is managed care, so over 90% of our population is in managed care. We in fee-for-service are not able to offer what's called value-added benefits, but in managed care you are able to. So what does that mean? Well, I have a long list of all of the value-added benefits that MCOs provide to members, and that includes cribs. They pay for the cost of GED classes and the test. They cover they give incentives to go to a preventive treatment or to go to the dentist. So they have cell phones available, especially in the rural areas. They have internet available for members. So they each have a program that offers what's called value added. So these are things outside of what we pay the managed care organizations. In fact, they cannot count their value-added benefits into their MLR. So really, these are extra things that are offered to our members that we cannot do in fee-for-service. Pilot programs. We hear all the time, well, can we just pilot this new idea? We can't do that in fee-for-service without going to CMS and getting approval, and generally that requires a waiver, which we'll talk about. But managed care organizations can immediately enter into pilot programs. They can innovate. They can contract with providers and with vendors and try new and different things to drive outcomes. So we're limited in fee-for-service. It's just not as easy for us to innovate. And then directed payments. So directed payments are where we direct what's called a supplemental. So we give providers either more money, based on a set of rules or requirements, or their reimbursement is tied to something different than what we traditionally would pay for. So in fee-for-service, directed payments, supplemental payments can only go up to what's called the upper payment limit. Under managed care, we're able to go up to what's called the average commercial rate. And if you have questions about that, that's why Steve Bechtel's here. But it is a difference. It's a higher reimbursement to go to the average commercial rate than it is to go to the upper payment limit. So we couldn't do that if we didn't have managed care. So that is a very high level, just to try to help you understand what is fee-for-service and what is managed care. So these are, when I talk about our state plan and the federal rules and regulations that we're required to operate under, we do have the ability to do different things and to get CMS approval for that. And those are what are called waivers. So we're asking them to waive something that's already in federal law or regulation. And the Secretary for Health and Human Services is the only person that can approve something like that. And it still has to align with the intent of the Medicaid program, which is to provide healthcare services for members, for low-income individuals. So there are 3 primary waivers, 1115 waivers. That is what I talked about. You know, if we wanted to innovate or do what's called a demonstration, we would file an 1115 waiver with CMS, and they would have to approve that. It has to be budget neutral. It has to track outcomes. It's generally 5 years in length. It can be extended. There's a great deal of work that goes into an 1115. There's monitoring, an intense evaluation. So it's a pretty large undertaking to do. 1915C waivers are those home and community-based waivers. They are the ones that we do use to serve our intellectually and developmentally disabled individuals or some of our older individuals. And I'm going to get into those here in just a little bit, but it does allow us to be more flexible in the services that we can cover. They're outside of the state plan, and they're more to meet the needs of keeping somebody at their home or in their community and out of facilities. And then the 1915B are what's called freedom of choice waivers. So our managed care organizations, for example, we are waiving laws that allow us to then put people into a managed care organization. So just to talk about the waivers that we do have currently in Kentucky, we have Team Kentucky 1115 waiver. This is primarily has to do with substance use disorder. We wanted to waive some requirements so that we could innovate around substance use disorder here in Kentucky and do some really great things. For example, there is what's called an IMD limit. That's institutions of mental disease. We can't pay for services and for individuals in an IMD. So we have been able to waive the requirement that that allows us to pay for folks that are in facilities that are over 16 beds, because otherwise we would not be allowed to do that. So we waived the bed limit, and we can cover people up to 95 beds. We also waived the length of stay in an IMD. It's right now under law, it's 15 days. We have an average of 30. So, because honestly, I think what we can all acknowledge is that 15 days isn't long enough for some individuals. So this gives us some more flexibility that as long as we're meeting the average of 30 days, people can be treated longer, which we think is very important. There were some other components to the 1115 that we waived that were non-SUD related. One was to cover former foster care if they were in foster care in another state. It's a law, and we do mandate coverage for Kentucky foster care kids, but this allowed us to also cover people from other states. We do waive non-emergency medical transportation for methadone treatment services. One of the reasons for this is that is a daily service, and primarily individuals that are seeking the service do have their own transportation. So we did waive that. We did a one-time aligning of Medicaid redeterminations to their employer sponsor plan. That's called Kentucky Health Integrated, it's KHIP, Premium Payment Program. So we will pay the premium of somebody's employer plan that qualifies for Medicaid, because we'll do a cost analysis. If it's cheaper for us to pay their premium than to pay for the services ourselves, then it's a good cost efficiency for us. So we wanted to align those enrollment periods. This current waiver expires in September. We're required by CMS to file an extension a year in advance, so we have already gone through that process. We've posted it for public comment. We got public comments. We send it on to CMS on September 30th last year, and so it is pending. The extension is pending with CMS at this time. And then while we had our original 1115, we did file an amendment in November of 2020. We many of the current members know about this, but it was to cover. It's a very innovative first in the country plan to cover folks going through incarceration. It would allow for us to cover some spots within somebody who's incarcerated, which the federal law doesn't allow us to do, as well as people that might be in custody and awaiting their trial. It would give us some flexibility to cover those folks and hopefully get them into treatment and maybe take care of the addiction that may be underlying their criminal actions. And then it would allow us some post as someone's getting ready to be discharged from a facility, a correctional facility. It would have allowed us to pay the managed care organization to work with that facility for that person so when they get discharged, they immediately have access to the prescriptions and or treatment that they need. So, and all that's arranged in advance, so there's a smooth transition. So that's for that 1115 waiver.
If I might, at this point, the point on that was it was submitted in 2020, and we're still waiting to hear. So sometimes when we submit things, the way they tell us no is to not tell us anything. I have at times given up hope on this, but I think there is more interest now at the federal level. We hear that other states are perhaps going to be able to proceed through this, so I haven't given up hope. But sometimes these things can take a while.
And we have CMS has initiated conversations recently with us to talk through the waiver. So we remain optimistic that we'll be able to get it approved. I mentioned managed care is already 1915B. The non-emergency transportation is also a 1915B, and the reason that is because it could be a state plan service is that in Kentucky, with the rural nature of our state, we do have to sometimes the broker who arranges for the driver, the broker provides the service because of a limit or a difficulty in finding drivers. So because of that, we have to have a waiver to allow the broker to do that. And that is also, no, you're fine. That's also a risk-based. So we pay a per member per month, like we do to the MCOs. We pay a per member per month for non-emergency transportation. So they have to deliver the services within that payment. And then 1915C waivers. As I mentioned, so they do get access to all the state plan services, but then they get access to additional services to meet their needs. List some of them here: case management, homemaker, personal care, adult day. So there are a lot of other services they have access to. They also, I noted on there, participant-directed services. So while we have providers enrolled in Medicaid, a member, otherwise known as a participant, can employ someone else. They can find somebody else that they want to employ, and so we will work with them to have that person provide services for them. It's a level of comfort. You know, these are folks who are intellectually and developmentally disabled, sometimes having people that they feel comfortable with and they know and are qualified. And let me say, they still have to meet qualifications, for them to be able to direct some of their care and who provides that. So we have 6 1915C HCBS waivers. The first 2, acquired brain injury and acquired brain injury long-term care. Those are for individuals age 18 or older that have an acquired brain injury. The Department for Medicaid Services operates those two programs. Then we have what's called Model 2. That's for individuals dependent on a ventilator for 12 or more hours, or who may be weaning from a ventilator. That is also operated by the department directly. home and community-based, which is kind of confusing because that's the name of the waiver, but there is a specific home and community-based. Those are for individuals aged 65 and older, or in any individual with any age with a physical disability. That is operated by our Department for Aging and Independent Living because of their expertise on aging individuals. The Department for Aging and Independent Living also operates the participant-directed services for all the waivers that have PDS as part of their program. And then Michelle P. waiver and our supports for community living waiver, those are for individuals with intellectual and developmental disabilities. And our Department for Behavioral Health, Developmental and Intellectual Disabilities operates those two programs on our behalf. This is a current snapshot. This is as of like January 4th of the members that are in each of the waiver. And I believe you might have heard that there are waiting lists. So we do have waiting lists for Michelle P. and SCL, the Supports for Community Living. I think it's important to understand that just because somebody's on a waiting list does not mean they're eligible for the program. We've not made a determination as to whether or not, even if a spot becomes available for them, that they're going to qualify for it. So that's important to understand. As the waiting list may grow, people may be sitting on it that aren't eligible. The other thing is that people may be on one of those waiting lists, but they might also already be in the home and community-based waiver program and receiving some kind of service. So please know that, even if somebody's on the waiting list, they are accessing services through maybe another waiver and receiving state plan services as a result of that.
So I think it's a time in that we come to time of our presentation where we allow Veronica to get her breath a little bit and maybe take some oxygen in for a little bit. But as financial people, we tend to get a lot deep in the weeds, and we tend to get a little weedy. So I'm going to do my best to keep it at a high level on the budget as possible. But just like Secretary said, as well as Veronica, I'm open, and I think some of you I've worked with, I'm open to discussion. I'm open to answer any questions that you may have. What you see before you, we in our budget in Medicaid, we have actually two appropriation units. We have the administrative appropriation unit, and we have a benefits. The benefits is the majority of our budget. It's about 97% of our total budget is the appropriations for the benefit program. So today I just want to briefly talk about the benefits appropriation unit. Like Veronica said, we have 10% of our population is in fee-for-service that are carved out of the managed care program, and 90% is in the managed care program. But of the 10%, we spend approximately 20 to 30% on those 10% members. Those 170,000 members, or just about 170,000 members, we spend about 20 to 30% of our budget on those. But it should be, because they are our most vulnerable, they're the sickest population and the ones that we need to focus on. But you'll see on this spreadsheet, on this slide, I presented you the what we've actually spent in 21, state fiscal year 21 and 22. Those are actual expenditures. And I broke it out by the appropriation units, by the funding, by general fund, restricted agency funds, as well as federal funds. All the way across, you'll see that majority of our funding comes from the feds, from CMS. We're about 80% of our funding comes from CMS, while the remaining 20% is either state general funds or through restricted agency funds. Those restricted agency funds are funded through provider taxes, as well as what we call IGTs is short, but it's intergovernmental transfer arrangements that we have with providers that are governmentally owned. So I provided you also what we are budgeted for 23 and 24. That's directly out of House Bill 1 from last year, and you can see what our appropriations are for that. I believe Senator Meredith said earlier, $15 billion. You can see across there we're budgeted 15.3 in 23. So far in 23, we do believe that we will meet that budget. We've done a review on that. So 24, we are budgeted 15.8 billion. I mentioned about the managed care payments. They're about where they cover about the percentage of the spend on managed care is about 70 to 80% of our budget. Now, I want to remind you that there's two things there, and Veronica touched base on it earlier, as the directed payments. Those payments are above and beyond the rates in which the managed care organizations pay. We're directing them to pay additional funds. So we have 3 directed payments, and it accounts for about 22% of the total spend that we send to the managed care organizations, and it operates much like a pass-through payment. CMS doesn't like the term pass-through, but that's pretty much what it is. Is we're giving the money to the MCOs to then direct those funds to those providers. We have 3, like I said. You have you have the hospital rate improvement program, which is the HRIP program. We pay up to the average commercial rate for the inpatient services as of right now, and I do believe you all have House Bill 75 on the table to discuss adding outpatient to that. We also have the ambulance provider assessment program. Those 2 programs, the HRIP and the APAP, if I may use the acronyms there, those 2 are provider tax based. Those are where we use provider taxes to fund those. So the state funds is paid through the provider tax, and we use restricted fund appropriations to process those payments on the state side. But we do draw in the federal share of those funds. The university directed payment, those are payments to our universities for inpatient, outpatient, and professional services. So you can see that from state fiscal year 20 up through, and that's through December of 2022, that last column. So far, since state fiscal year 20, we have spent $6.7 billion in total funds through these 3 directed payment programs. This last slide that I'm going to be going over is about the waiver expenditures, the 6 waivers that we're talking about. I wanted to show you how much we spent in total funds in 21 and what we spent in 22 and what that comparison looked like. You can